Okay, I'm Dr. Margaret Tunney. I'm a licensed pediatric psychologist at Kennedy Krieger and Johns Hopkins University. And today I'm going to focus on coping and adjustment, specifically strategies for keeping kids motivated. I am a psychologist on our inpatient neuro rehab unit, so I provide services to patients during their inpatient admission. No disclosures, but there are no known studies regarding psychosocial treatment in AFM, so these are all kind of pieces related to anecdotal information we've gained based on all of the patients that we have treated here at our institute. So I'm going to go over a little bit of developmental considerations when thinking about coping and adjustment in AFM, give an overview of the psychosocial pieces and some additional contributors, models of behavior and anxiety, which are important considerations, and then getting into some intervention considerations. So pieces related to antecedent management, consequence management, and reinforcement programs. With regard to developmental considerations, it's important that we start here when thinking about how to help motivate kids. Most AFM cases, as most people know, are in young children. The age at onset is 5.5 about years of age. And we know that patients in peak years tend to be younger than those in non-peak years. So we have a greater number of kids in this 5-year-old range when they first have onset of this diagnosis. So for that reason, I'm going to focus on some of the interventions in this developmental area. The age range when children are becoming a little bit more independent and autonomous when their environment is happening here. And this rapidly changes over the course of only a few days during onset. So that autonomy and independence with their environment drastically changes pretty quickly. Psychosocial overview. So some common presenting concerns we see with this diagnosis. Primarily, we see anxiety. We see separation anxiety, which may include crying, frequent requests for caregivers, requests for repositioning or suctioning before the caregiver leaves. We see procedural anxiety. This can be related to vent weaning, capping trials, E-stim, speaking valves. And we also see some generalized anxiety, that kind of day-to-day anxiety. We see behavior in this population, which may look like variable participation in therapies and cares. We, interestingly enough, see difficulties with oral feeding in terms of kind of behaviors related to transitioning from a tube feed to oral feeding, some sleep disruption, mostly related to anxiety, and then depression. There was one study that did look at depressive symptoms in AFM, a little bit of a younger or an older population, but about 37% of those patients reported depressive symptoms 3 months after onset. So it's important to know that that's a possibility as well. Of note, we have seen and observed decreased concerns with repeat admission. So over time, these do decrease. Some additional contributors that we see is the setting. In a rehab setting like we are, that's not a normal childhood experience to have to be in a rehab admission. There are a lot of task demands, multiple hours of therapy per day. So that adds a lot onto the child's plate. Pain can be a contributor, fatigue, diminished functional control, having to rely on other people to do things that they previously were doing on their own, so they're waiting on other people, and communication barriers. Communication can be quite effortful for some kids, so that can really contribute to fatigue and some psychosocial pieces. So I want to start with some behavioral models. It's important to understand the components related to the presence of a behavior. We usually start with what we call the ABCs of behavior. The A being the antecedent to a behavior, so things that are occurring right before the behavior that impact the probability that that behavior happens again. And then the B is the behavior itself, and then C is the consequence. So the consequence would be what occurs right after the behavior. I don't love the term consequence. It's part of the model, but it's really just referring to what happens after. And then thinking about the functions of behavior, there's 4 common functions of behavior. One being access to social attention, so behaviors may be seeking that. Can also be access to items or activities, so attempts to gain access to things like electronics. Escape or avoidance of a task or an unpleasant stimuli, something that is distressing. And sensory stimulation, or that sensory input. Since we see so much anxiety, it's important to think about this cycle of anxiety, which is common. So behaviors such as avoidance and escape are really common within anxiety, and there's a reason that they happen. Understanding what's underlying and driving the behavior is important, because this informs the treatment approach and how we can best support children. So if you think about a stressor, that box on the top, this can be real or a perceived stressor of some sort. This triggers an alarm that kind of goes off in the body, and that triggers symptoms of anxiety and panic, an increased heart rate, those butterfly feelings, things like that. When that alarm goes off, our instinct as humans are to avoid or escape that stimuli. The problem with that is when we do that, there is some short-term relief, so that anxiety temporarily in the short term, it does work, and the symptoms subside. What we can probably imagine is the issue is that long-term consequences happen. So if we're constantly avoiding or escaping those fearful or distressing stimuli, we never learn how to manage those. And so those symptoms actually increase and build. So anxiety can get worse. So thinking about how do we help kids? How do we intervene and support them, especially at the early stages after onset when they may be experiencing the most concerns? First being with regard to procedural anxiety, this can occur during various interventions, trach changes, vent weaning, speaking valves, e-stim. So we want to provide developmentally appropriate education. It's important that kids know what is happening to them, what procedures they're going to receive. And then as needed for kids who are quite anxious about those medical cares, we can provide systematic desensitization as needed. And what systematic desensitization is pairing some relaxation strategies with systematically increased exposure to stimuli. So starting with something small related to that medical procedure and building from there and exposing kids to that piece by piece rather than all at once, which may be overwhelming to them. We also want to provide guidance to caregivers on how to address separation anxiety, because this can be tricky. Some of our instincts with regard to treating separation anxiety can actually be more problematic and can increase it. So the way we want to treat this is to notify the child of the caregiver's departure and have them let the child know when they're going to return. Have a brief separation process. We really want to avoid that being long or prolonged in any way, because that can really increase anxiety and distress, and kids can have a harder time rebounding from that. And then it's essential that the caregiver returns at the predetermined time. This really builds trust between the caregiver and child, that when the caregiver says they're going to be back, they do come back, and that the child can trust that. And then over time, we can systematically increase the frequency or the duration of separation until families are in a more comfortable place where caregivers can step out of the room or be in another place to make a meal or whatever they need to do in their day-to-day life. Teaching relaxation and coping skills is important, and that training can help with emotion regulation. Those emotions can interfere with kids' motivation and participation. So teaching some skills for managing that can be really important. Those could be, for some kids, diaphragmatic breathing. Some can be imagery, imagining a happy or peaceful place. Brave statements. These are really positive self-statements that can help build their confidence. For younger kids, it's going to be important to include caregivers in this, because they're the ones who are going to be with the child day to day, and they can help prompt those skills and practice with the child to generalize throughout the rest of the day. We want to use modifications to play so that kids can engage in games and activities. This could be adaptive equipment, hand-over-hand support. This is helpful because kids can then be more engaged in preferred activities during sessions and therapies. And we also want to provide caregiver support for coping and adjustment. We know that caregiver reactions and interactions with their child can impact the child's coping. Children take cues from their caregivers for how to interpret and react to their environment. So when individuals in the environment are overwhelmed, children become overwhelmed. When individuals are calm, children are better able to cope with events. So caregivers can be a really powerful tool in their child's coping, but we want to encourage caregivers to care for themselves too. Because as a parent, their first instinct is going to put their children's priorities and needs first, of course. So I like to remind families and caregivers to, just like you're on an airplane, there's a reason they tell you to put your own mask on first. And that's because you need to be able to take care of yourself before you can take care of kids. So don't put your own coping and adjustment and support off, and make sure that you're accessing those resources as well. Some antecedent management things. So this is the A of those ABCs, things we can do in advance to help reduce the likelihood that behaviors occur. It's really important to prioritize therapist rapport. A child's rapport with their therapist is really important. This increases trust, reduces fear during difficult and novel tasks. Important to incorporate preferred interests and items into therapy sessions. Prioritize session task demands. So think about what are the priorities of that session and prioritize those, and try to reduce the task demands that aren't really essential to that session. And those can be systematically increased over time, but starting where they're successful. When we're giving task demands, it's important to use short and simple language, avoid long sentences, excess language when we're presenting that task demand. It's of course absolutely appropriate to provide information to the child, but we want to do that prior to actually starting the task, because otherwise that can contribute to some delay behaviors where kids start to ask a lot of questions and it delays or puts off whatever it is the task demand is, and that anxiety can build during that time. We want to provide opportunities for control, and this can be through choice, choosing the order of therapy activities, the game, color of their kinesio tape, whatever it may be, but giving them some choice. And built-in rest breaks. There's lots of therapy needs for kids, and it's important that they don't become too fatigued and start to dread those things. We want them to enjoy them and look forward to them. Thinking about consequence management, that's that C of the ABCs. And this is really thinking about after a behavior occurs, how are we responding to that? What's occurring after? So we want to encourage utilization of differential attention. And what that is two different components. One being positive praise and attention for all adaptive and desirable behaviors. When kids are participating, they're being brave, they're engaged, we want to give significant positive praise and attention for that. That's really where we should spend the most of our time. When there are maladaptive or undesirable behaviors occurring, we really want to neutrally respond to those and reduce attention. And really focus on when they are presenting with those adaptive behaviors and giving lots of praise for that. We want to make sure that we're reducing the effectiveness of escape and avoidance behaviors. So thinking about when those behaviors may be escape or avoidance, and making sure those aren't effective, because if they are, it's going to contribute to more and more anxiety. We want to train caregivers, staff, teachers about how to use adaptive responses to behaviors and anxiety. Sometimes people's instinct is something that may contribute to more anxiety, and so giving appropriate training and education is important. And then to consider reinforcement programs as needed. These are not always needed, but they can be really helpful in increasing desirable behaviors and adaptive behaviors. So here's a few steps or considerations when thinking about developing a reinforcement program. The first one just being identify a behavior and the earning criteria. We want to start with one target behavior, try to avoid multiple, keep it pretty simple, it should be realistic and achievable for the child. And with regard to the criteria for earning, initially we really want to make the system that we know the child's going to achieve and earn rewards. And then over time we can change that, but we want them to be successful initially. And be flexible with this. We need to modify demands. So we may have lower demands initially to get them started and increase that over time. The second step would be to choose a reward. And this is important to individualize this to the child's interest. They're going to be more motivated by something they're very interested in. And these by no means need to be monetary. This can be a social trip somewhere that they were looking forward to. It can be a special game night, anything like that. We want to also think about limiting competing reinforcers. So if the reward you choose is something they have access to all of the time, they're not really going to be motivated by that. So making sure you're choosing a reward that's different and limiting some of the other reinforcers or things occurring throughout the day that may compete with that. The third step to be creating a chart or a visual. This helps kids understand the program better, and they're going to be more involved and interested in it. It reminds the child of what the rules are, how they're going to earn, and they're more excited about those things. The fourth step to be explaining the program to the child. So show them the materials and double check that they truly understand. The program is not going to be effective if they don't understand what's being asked of them and how they can earn. Step 5 is use the program, give it a try. Consistency is very important. This establishes a good connection between the behavior and the reward. So make sure you're consistently using the program, not only waiting to pull it out when the child's having a more difficult session. We want to use it consistently all of the time so that it's more effective. And as soon as the child demonstrates the target behavior, they should be earning right then. So that reinforces the connection between those. If that reinforcer is delayed, the child doesn't associate it with the behavior as much. So there's less learning opportunity there. And step 6, once you achieve some higher rates of goal behavior, you're going to look at slowly modifying or phasing out the reinforcement program. Reinforcement programs don't need to be there all the time. They can be used temporarily to start up something more difficult for the child and then fade it out later as it becomes more of a habit and they're more comfortable doing it. But some modifications can be made. So that could be modifying the task demands, modifying the earning criteria, whatever the target behavior was, or even the theme of the program itself, changing from superheroes to Paw Patrol. And then fade out that system as needed. Here are my references. Thank you, everybody. And thank you to all of the families that I've had the pleasure of working with, and I've learned so much from them, and hope others can use some of these things in helping to support kids as they're in rehabilitation and other therapies. And I'd like to introduce Dr. Lana Harder, and she is going to be talking about advocating for your child in the school system.